have we improved the care of non-clear cell kidney cancer patients? Kidney cancer has 70% of kidney cancer is clear cell kidney cancer. So we talk about kidney cancer, we always talk about clear cell kidney cancer patients. And they represent about 80% of metastatic kidney cancer patients that we deal with. The remaining 20% of metastatic disease, lots of them, about 15% of them are papillary type of kidney cancer, and some of them are chromophobe. And then there are other rare ones, SDHB, TFE3, collecting tongue medullary type. So those are rare disease. So we have this consortium and this effort from a patient advocate. We established something, a website called rarekidneycancer.org. So it's rkcancer.org. So the idea is basically these patients are so few. Then how do we provide the best care for them? So as I told you, in a very rosy way, that we move from dark age to modern age to golden age. But non-clear cell patient is still in almost dark age to me. Okay, that's very, very sad. What happened was, as I said, in the past, the median survival for metastatic clear cell patient is about 15 months. Now we're almost 30 months. We're going to move it to 60 months. But for non-clear cell patients, especially papillary patients, it was 12 months. Nothing changed. So we know they work better on the anti-VEGF treatment, better than mTOR inhibitors. And a good thing to know is that the trial that we conducted using Avastin plus everolimus showed efficacy. Again, showing the combination is very important for kidney cancer. But it's not standard, and everybody still try to figure out how to treat non-metastatic kidney cancer patients. I think the community, the doctors community is trying to do by accruing patients to the right trials. But I think we also need to raise the patient's awareness and engage them from participating, and also their local treatment oncologists educate them so we can actually move the field faster that way.
Non-clear cell renal cell carcinoma has been an enigma. It's been a very difficult cancer to treat, and most of the drugs that we have available for us to choose in clinics have been predominantly designed in the clear cell histologic subtype. There are several agents, however, that hold some promise for non-clear cell histologies. I'm personally the PI of a phase 2 trial that is ongoing, which looks at the combination of lenvatinib and everolimus in this patient population. Cabozantinib, being a c-MET inhibitor, also may have unique opportunities and activity in this cancer, as well as IO therapies. Nivolumab has launched clinical studies in non-clear cell histologies. In addition, there are other TKIs in development and phase 3 trials. One of them is called the phase 3 Savior trial, which Tony Tereri is evaluating with savolitinib, which is an inhibitor, a c-MET FGF inhibitor for this cancer.
For patients with papillary histologies, there are combination regimens that appear to be promising based on phase 2 data that has been presented by different groups. The combination of bevacizumab plus erlotinib has been tested by the NCI group in patients with papillary kidney cancers, including a high proportion of patients with underlying hereditary predisposition syndromes, specifically HLRCC syndrome, and a high level of clinical activity was seen particularly in that space. Our own group has reported on a similar combination in this patient population also, and we have published on the combination of bevacizumab plus everolimus, which in the first-line space we also found to be highly effective, particularly for patients with major papillary components found in their tumors.